Hello and welcome to 12 Lead Part 5, What Gets Missed. This is where I'm going to talk about some of the parts of the heart that we don't see clearly with our standard 12 lead, some clues as to when you might want to look a little further, and some ideas about other clues to a significant cardiac event that don't meet our typical STEMI criteria. So as I've mentioned in earlier videos, we have a pretty comprehensive view of the heart with our 12 lead. We're getting views from two different planes, horizontal and vertical, get 12 different views of the heart, and we do a good job of seeing the anterior lateral portions of the heart, but not so good job of seeing either the right ventricle or the posterior portions of the heart, and those are the areas I'm going to talk about primarily here. So when we think about our V leads in particular, chest leads are looking at the front of the heart, but what they don't look at effectively is the right ventricle, and they don't look effectively at the posterior. But where the leads are positioned can give us some good clues that there may be reason to suspect something going on in those areas. So some clues that might get us thinking about a right ventricular infarct is any inferior MI. The inferior portion of the heart is primarily fed by the right coronary artery, which obviously also feeds the right ventricle. So if you have an occlusion, especially a proximal occlusion of the right coronary artery, you might have both a right-sided and inferior involvement. Any acute MI symptoms with hypotension are a clue of right-sided involvement. Any ST depression, or especially significant ST depression in your lateral leads with no ST elevation in your initial 12 lead, may be a clue that that ST depression is actually reciprocal and is actually showing you the evidence that there's something going on the opposite side of the heart that we aren't looking at that point. JVD. Keep in mind that right ventricular infarcts cause a backup of fluid, and when the backup of the fluid is coming from the right side of the heart, it backs up systemically, and sometimes the first place you see that is jugular venous dissension, that inability for blood to drain back into the heart. And finally, dyspnea with clear lung sounds. In left-sided failure, we expect RALs. We expect that fluid's backing up into the lungs and can cause evidence of that fluid in the lungs. But if it's the right side, then the backup in the pressure may still create a sensation of dyspnea because your patient's hypoxic. They're not oxygenating adequately, but there isn't fluid in the lungs, so that's another helpful clue. Here's an example of a 12 lead that if you look at the standard lead views we're looking across, there is no noticeable ST elevation in any of these leads, but there is significant ST depression across V4, V5, and V6. This is a clue. It's not diagnostic in itself, but in the presence of acute MI type symptoms or any of the factors that I just listed would be a great reason to suspect that something else is going on. Again, V4, V5, and V6 are looking at that lateral portion of the heart, the anterior lateral portion, and if they're showing depression, it could be evidence of ischemia on that side closest to the leads, or it could be evidence of an infarct on the opposite side. So rather than it showing us anything about the left side, it's showing us reciprocal changes that are evidence of the large infarct that has occurred on the right side of the heart. So if we decide that we suspect a right-sided MI, we can take a look at the right side. And a full right-sided 12-lead placement would look like this. You simply reverse all the leads. Placement is the same, but on the opposite side of the chest. The other option is to simply place 4, 5, and 6. So you bring over your V4, V5, and V6 and put them on the right side and acquire another 12-lead. What that gets you in this example is you can see we have big inferior elevation, an obvious inferior infarct in this patient. And when we put our right-sided leads on, we also see huge ST elevation in those right-sided leads, which is confirmation that there is also right-sided infarct. Now, it's important to note that none of our current ECG machines that I'm aware of have the programming to print it out on the sheet like what you see here. This was added for teaching purposes, but it is critical that if you're going to print this off, if you're going to include this in your report or hand it off to someone else, you need to clearly indicate that these are right-sided leads, because what will typically show up is V4, V5, V6, which could be very confusing to someone if this view that you're presenting is actually looking at the right side of the heart, not the lateral portion of the heart. So what does it change? If you discover a right-sided infarct, it's appropriate to use fluid to treat hypotension, and it may require a significant amount of fluid. Essentially, we're recognizing that we're lacking preload, that right ventricle isn't stretching. We're hoping to take advantage of that Frank-Starling mechanism where a little increased stretch of the right ventricle will produce better forward flow. We want to use large bore IVs, and we may want to use caution with vasodilators. And I say may because this is somewhat controversial. What we know is that some patients having an acute MI are going to react dramatically to nitroglycerin or anything that vasodilates and may have a profound drop in blood pressure. At one point, it was believed that that was more of an issue or more problematic with right-sided MIs, but that concept has been pretty much debunked. What we know now is that any MI with a borderline blood pressure has the potential to become significantly hypotensive. So in patients who aren't hypertensive, we should be cautious in using vasodilator, regardless of the actual location, the specific location of the MI. Another thing that we can consider is the posterior portion. Similarly, our V1, V2, V3 leads are looking at the anterior surface of the heart, meaning that significant ST depression there might be a reflection of an infarct in the posterior wall. In this example, you can see that we have in V1 through V4 significant ST depression, but no ST elevation showing up anywhere else. So again, in the context of a patient who seems like they're having an MI, is having the signs and symptoms consistent with that, but you haven't found ST evidence, this ST depression might prompt you to think about the possibility of a posterior MI. If we look at that posterior view, we might be able to see ST elevation, which would help to confirm that. We should suspect a posterior infarct if we have a large inferior lateral MI, if we have the ST-type depression that I just showed you in V1 through V4. Those are clues, those are hints, but as it says here, usually a posterior MI is an extension of an inferior lateral MI, and it's not commonly going to be seen in the absence of any other ST elevation, but it's absolutely possible. Here's a picture that kind of depicts where we do those. So from a cross-section view, you can see that we're simply going to continue wrapping those leads. Again, we can simply take our V4, V5, and V6 wires and clip them to V7, V8, V9. They are at the same anatomical level as V6 and just come straight around the back as illustrated here. Again, we have to label them. We need to make sure and identify clearly on our printout that this is an example of a lead view from the posterior section, and that's typically labeled V7, V8, and V9. The rest of the leads are the standard leads. And in this example, again, we have some inferior infarct showing here, as well as posterior ST elevation. So what does it change? This is probably not as significant as finding a right-sided MI, but it is possible that you're going to identify a STEMI that is otherwise missed. Could make you look cool to the cardiologist. It could shorten the time period it takes to get a patient to a cath lab and to a definitive intervention. Probably won't change the specific treatments we provide to these patients, but it certainly could help in us being more comprehensive in our assessment of the amount of myocardial damage. The next category I want to talk about is NSTEMI, or non-ST elevation MI. And this is a little confusing for some people. This is not a non-MI. This is not saying the patient isn't having an MI. This is saying this is a myocardial infarction, but I don't have the clear evidence that an ST elevation would give me. In many systems, ST-MI is the only, that ST elevation MI is the only criteria that's going to get you a straight trip to the cath lab or to immediate intervention. However, we can still use these tools to heighten our awareness and increase the chance that we're going to verify an actual MI even without that clear evidence. One of the most common imposters, one of the things that looks like a STEMI when it's not, is bundle branch blocks, left bundle branch blocks in particular. Now, left bundle branch blocks, as I said in another video, are also a really common occurrence in a new MI. So one of the criteria that we look at is a new onset left bundle branch block is likely to be caused by an acute event. And there's some criteria we can look at in the presence of a left bundle branch block to determine if this is likely an MI. This is termed Sgarbossa criteria. It's been around for a long time, and there's a few of them here. The specific details of this are beyond the scope of this short video, but a quick overview is that Sgarbossa 1 says that if you find ST elevation of greater than 0.1 millivolt, in other words, greater than 1 box, in the same direction in the QRS, in the leads where the left bundle branch block is positive, in other words, if you have a bundle branch block, a big QRS complex that's positive, and in those leads where it shows up, where the QRS is positive deflection, there is also ST elevation in the same direction. That is a significant finding and likely indicative of an MI. Sgarbossa 2 and Sgarbossa 3 get a little more involved in that if you look at V1 and V3 specifically under Sgarbossa 2 and you see ST depression in the same direction as the QRS, that's considered significant. And if you have ST elevation in the opposite direction of the QRS in left bundle branch blocks or paced QRS rhythms, it's potentially an indicator. Now again, this gets beyond the scope of this. If you're more interested in using the Sgarbossa criteria, you need to read more about it, look at the examples, practice this, but it's a good example of some other fine-tuning, so to speak, that we can look closer at our 12 lead and use other criteria to determine our index of suspicion for an acute cardiac event. Another set of categories are the Wellens criteria. Wellens looks at T waves. So if you have biphasic T waves in your anterior leads, that is highly indicative of an occlusion or a blockage. Wellens type B is deeply inverted anterior T waves. With both of these, they may or may not be accompanied by chest pain. They may or may not have obvious cardiac symptoms, but they're all indicative of an abnormal conduction that might be the result of an occlusion. Another one I like to talk about is AVR. We looked at, in standard interpretation, we look at every other lead and draw conclusions from those other leads, except we just sort of ignore AVR. What if AVR has ST elevation? Well, one factor here is that ST elevation, to be diagnostic, we need to have 2 or more contiguous leads, and AVR sits off by itself and nothing else is looking close to the same area. So that's part of the challenge. However, if you see, like in this example, clear ST elevation in AVR, and depression across multiple other leads, as shown in this example, that is indicative of a problem. And I say a problem because there's several problems that could contribute to this. One primary cause is a major occlusion of the left anterior descending artery. But that is only responsible for this presentation about 1/3 of the time. There are other things that can mimic this and produce the same combination. One of those being any shock state. So a septic patient, a patient who's in hypovolemic shock. A variety of shock states can present with patients who have widespread ST depression and elevation in AVR. Because it is not very specific, this is rarely used as criteria for cath lab by itself, but it is another one of those clues, another thing that should cause you to take a closer look. So how do we know who needs to go to the cath lab with all these variable criteria? Like I've said before, it's the story. Does it sound like an MI? Does it sound like they're a candidate? Do the pieces fit together, and do you believe that this cardiac presentation is the result of an occluded artery, in which case they're likely to benefit from a cath lab and a definitive intervention? Know your coronary artery anatomy. That's where using the 12 lead for localization is great, because as you identify a right-sided occlusion, for example, you know what to expect as far as where that's going to show up. Or the converse, if you see inferior or right-sided infarct evidence, you know that the right coronary artery is the one that's occluded. Knowing the areas of the heart will help you anticipate how your patient might respond to what they're dealing with, as well as to the treatment strategies that we deploy. Remember that a normal 12 lead does not mean that your patient is not having acute ischemia, injury, or infarction. And I'll say that again because this is important. We use the 12 lead because it is a very definitive diagnosis when it hands us that diagnosis on a platter. But not all MIs are going to produce ST elevation. Not all MIs are going to produce ST elevation early, even if they produce them later. So when we have a patient who seems to be having an MI, we should manage that accordingly. We should follow our acute coronary syndromes algorithms. We should treat our patients aggressively and appropriate. And if we don't have proof of an ST elevation MI, we should continue to take repeat 12 leads in case it's a evolving event and that evidence shows up later. In my next video, I'm going to talk about bundle branch blocks and axis determination.